First, I would like to thank the organizing committee for the invitation to give this lecture on the treatment of alcohol-associated hepatitis. Here are my disclosures. As you know, alcohol consumption is increasing all around the world because of the social and systemic crisis. And consequently, more and more patients are being hospitalized for complications related to alcohol-related liver disease. The COVID-19 pandemic has amplified this, and as this study by our Canadian colleagues demonstrates, the rate of hospitalization for AAH doubled between September 19 and September 20. To address this growing problem, we need key points for identifying the challenge. First point, depending on the presence of typical criteria and the possibility of having a liver biopsy, we will speak of definite, probable, or possible AAH. Second point, it is essential to identify the severe forms because the prognosis depends on them. Using the MADRE function from 32, we identify the severe disease, the severe form of AAH. Below 32, or in cases of MELT less than 21 or bilirubin less than 85, we have the less severe disease, and as you can observe, the mortality rates are quite different, 20 to 50% at 28 days in the severe form, 6% at 28 days for the not severe form. And today, the lecture will focus on the severe form of AAH. Let's see now the outline. First, the current therapies with two areas. First, how to decrease the short-term mortality at 28 days and 3 months. Second, how to decrease the long-term mortality over 6 months. And I will have a word about the emerging therapy. First point, it is obvious for me that steroids are the backbone of the short-term treatment. And despite numerous studies and the endorsement of both AASLD and EASL guidelines, the place of steroids in the treatment of severe AAH remains a source of controversy. And yet, in this meta-analysis of individual data from controlled trials, it was clearly demonstrated that steroids treatment significantly decreased the risk of death within 28 days, compared with controls and pentoxifylline. There was no difference in 28 days mortality when patients were given a combination of steroid and pentox versus steroids alone, or between patients given pentox versus control. And in the analysis of secondary outcomes, they found no significant difference in 6 months mortality when any treatments of control were compared. That means that, yes, steroids are efficient, but exclusively in order to decrease the 28 days mortality. The second point is, have we a stopping rule? Yes, we have. When using steroids, there is a stopping rule. But by combining day 0 and day 7 parameters into a score, age, albumin, evolution of bilirubin at day 7, renal failure, and MADRE function, it is easy to identify the non-responders with a score up to 0.45, and then to stop a treatment that has become useless. So we have the efficacy and we have the stopping rule. But we have to consider possible contraindications to steroid. And as you know, infection is a frequent event in severe AAH, and is one of the major factors influencing mortality. And ongoing infection is a contraindication to initiate treatment with steroid. And in this very nice study from our colleagues of Lille, more than 600 patients with AAH, infection at admission was 33%, with a third of them with lung infection. And as you know, it affects survival. So we have clearly to identify infection before starting steroids. The question of whether steroids predispose patients with AAH to infections is debatable. The meta-analysis of all randomized controlled trials on steroids in AIH, which I have already mentioned, showed that patients treated with prednisolone had no increased risk of infection compared to patients treated with placebo. All these results give us an algorithm to have the decision to treat patients with steroids. Patient admitted for severe alcoholic hepatitis. First, we have a systematic screening for infection. In the absence of infection, we can start prednisolone, 40 milligrams per day for 7 days. At day 7, we assess the treatment response with a Lille score. In good responder, we can continue the treatment for 28 days. In non-responder, and specifically in patients with Lille score more than 0.56, we have to stop the treatment. And on the other hand, in patients with infection, we have to start antibiotics. If the infection is cured, we start prednisolone. In the case of persistent of infection, at now, we have no validated treatment. Let's see now if we can add a drug to improve the result with steroids. Here you have two examples. The first one with pentoxifylline, which have been proved to have anti-inflammatory effect and to decrease hepatorenal syndrome in patients with alcoholic hepatitis. As you can see, even if they seem to have this protective effect, the hepatorenal syndrome, here it was ineffective as an adjuvant to corticosteroids in order to improve survival. And concerning antibiotic, it was very voluntary to add antibiotic because of the high rate of infection. And there was a randomized control trial designed to determine if antibiotic prophylaxis used as adjuvant to steroids will reduce infection risk and improve outcomes. This trial has been performed, and unfortunately, again, the results are negative. More interesting is the use of N-acetylcysteine, NAC, as an antioxidant. This French double-blind randomized controlled trials of patients with severe AH treated with NAC and steroids demonstrated an improvement only in the 28-day survival, primarily related to the reduced infection rates, whereas long-term benefits were not observed. And meta-analysis of 22 RCTs noted that the addition of NAC to steroids may be superior to steroids alone for reducing short-term mortality. So, in order to decrease the 28 days and 3 months mortality, we can use steroids, and in some cases with N-acetylcysteine, and the efficacy has been proven. But the problem is what to do and what to expect from non-responder to steroids. And as you know, in 2011, there was a thunderclap, a case control study of 26 patients undergoing liver transplantation and compared to 26 matched control. And the result was very clear. 70% survival in patients undergoing transplantation, well selected, and only 23% of the matched control, meaning the non-responder without transplantation. Considering this point of liver transplantation, one point needs to be stressed. Beyond the Lille score at day 7, the MEL score must be taken into account because it refines the risk of mortality at 6 months and makes it possible to identify the patients with urgent need of transplantation. That means that you have a poor Lille score but a low MEL score below 20, probably you do not have to consider transplantation. On the contrary, with a MEL score of 25 or 30, you have to consider transplantation. In the editorial from Pratin Kamat related to this paper, it was called melding the Lille score. The French results, the initial French results, have been confirmed in the US consortium called Accelerate AH, a cohort of 147 patients. Mortality without transplantation was up to 70%. Excellent 1 and 3-year survival rates were observed after liver transplantation, 94% at 1 year and 84% at 3 years. But there was a warning in terms of significant alcohol use after transplantation, 10% at 1 year, 17% at 3 years. And in the US cohort, the patterns of relapse have been the subject of a specific study. And as you can see, results indicated that 70% of patients had remained abstinent, good news, but there was 30% of relapsers, and they were divided by time to relapse and intensity of alcohol use as follows: early mild relapse, 15%, early heavy relapse, 8%, and late mild relapse, 6%. That means that 23% have an early relapse. And when this relapse was compared with the other profile regarding survival, as you can see, early relapse, whether mild or severe, had the greatest impact on 5-year post-transplant survival and was associated with primarily alcohol-related mortality, half of the deaths related to early relapse. All these studies were retrospective, and we have the same results in a prospective French multicenter study comparing 3 groups of patients: transplantation for AAH, transplantation for alcoholic-associated cirrhosis without AAH, and no transplantation for AAH. When comparing alcoholic hepatitis and cirrhosis patients, no difference was observed in terms of survival on the left part of the slide. On the other hand, there was significantly more heavy drinking patients in the group with alcoholic hepatitis compared with the group of cirrhosis, because in this group of patients with cirrhosis, there was an abstinence of 6 months before transplantation. And it has been shown that a post-transplant excessive alcohol consumption has an impact on survival, especially beyond 5 years. In this study, the endpoint was at 2 years. And so that means that in this situation of liver transplantation for non-responder alcoholic hepatitis, we need addiction specialists within the transplant team to improve the results in terms of alcohol relapse because of the poor consequences. Let's see now what happens after 6 months in the survivors. This may seem like push and open door. The point is to emphasize that in patients who have survived a severe episode of alcoholic hepatitis, continued management is necessary to avoid the potentially life-threatening relapse. In this Spanish study, there was a significant impact on survival in relapsers on the left part of the slide, comparing complete abstinence with relapse. And one of the strengths of this study is that it allowed to identify patients at high risk of relapse, meaning young patients less than 48 years, and those with a history of alcohol addiction treatment. So in the long term, abstinence is a cornerstone to improve survival. To finish, what about emerging therapies? Identifying the targets, considering effects of alcohol on gut and hepatocytes, we have drug acting as a gut-liver axis, anti-inflammatory agent, and regenerative agent. Many studies are ongoing, most of them randomized controlled trials with different concepts: reducing bacterial translocation, changing gut microbiome, and anti-inflammatory agent, regenerative agent. I would like to focus on one promising open study. EL22 has beneficial effect on inflammation and impaired hepatic regeneration. In this study, 18 patients, 9 with moderate and 9 with severe alcoholic hepatitis, receiving IV perfusion at day 1 and day 7. There was a significant decrease in MELD and aminotransferase at day 28 and day 42. And as you can see, at day 7, the LIL score has improved in 83% of the patient exposed to the IL-22, and this is promising, needing to be confirmed in a phase 3 study. So to conclude, we have 2 periods: the short-term period, considering probable or definite alcoholic hepatitis, If there is no contraindication to steroids, you have to treat them, hoping to reverse them, and you know what happens at what week. In patients not treated or no reversal after transplantation, after steroid, the non-responder, candidate to transplantation. If yes, you can evaluate them. If no, you have to discuss the GOS of scores if ICU, specifically in patients with more than 3 organ failure. And in the long-term period, clearly, the abstinence is the cornerstone with a minimal risk of death in absence of relapse in the good responders, a substantial risk of death in the non-responder abstinent, and a high risk of death if the non-responder will alcohol relapse. Thank you for your attention.